Good morning, ladies and gentlemen. It's way past 8 o'clock in the morning, and I think we better start. My name is John Camm, and I'm from London in the United Kingdom. And I'd like to welcome all of you to this second Global Left Atrial Appendage Occlusion Summit. Some of you were here for the first one, and I'd like to welcome you back. There are new faces at this second meeting, and welcome to you for the first time. Before we actually get started with the program, I think it would be interesting to find out who all our audience are. So I wonder if we could, since we don't have any modern technology like clickers, if we could just put our hands up in response to these questions. How many of you are cardiac interventionalists? Thank you. And cardiac EPs? And neurologists? We have one I can see. Is there more than one? Okay, so one neurologist. We'll try and protect you. Don't worry about it. And are there others that I'm not mentioned? Yes, what do you, sir? I can't see. What? Clinical cardiologists. Good. How many clinical cardiologists? Okay. A few clinical cardiologists. Well, once again, welcome. I think that I should mention that telephones should be switched off or put into mute. There seem to be fire escapes on 3 of the corners of the room, so if there's a fire, don't go in that direction. It seems to be the only way that not going out. And I have a slide that tries to set out some of the meeting objectives. Basically, as you know, we're here to discuss left atrial appendage occlusion or left atrial appendage closure. People are sometimes backing the term closure and sometimes occlusion, but we're here to discuss that, and in particular, to try and put it in perspective with other antithrombotic measures in atrial fibrillation, and to explore what its place might be, particularly who are the patients who should receive a device of this nature. So with that in mind, I think I should begin the program, but over to you, Rita. You wanted to say something first. My co-chairman, Rita Ibrahim, and Torsten Lewalter.
Welcome, everyone. We are very pleased to have you here today. So let's just start now with the program, and there's no better speaker, I think, to begin this morning than John Camm. He needs no introduction. And we will start just to review the guidelines on atrial fibrillation. And as you well know, he's the chair of the European Society guidelines on AFib. So, John, please, thank you.
Thank you. Thank you very much. So my intention now is to quickly review the current global guidelines for the management of atrial fibrillation with regard to thromboprophylaxis, and to tentatively ask what the place of left atrial appendage occlusion might be. At the present time, as you know, there are no international guidelines that have given any particular place or any particular recommendation to left atrial appendage occlusion, but certainly the ESC guidelines that will be available at the meeting in Munich in the summer will certainly have recommendations on this topic. So first of all, of course, I have some disclosures, some of which may be relevant to this talk. Secondly, I think it's worthwhile remembering that the early forms of atrial fibrillation, which are characterized by an atrial fibrillation not associated with substantial fibrosis, not associated with substantial myocyte loss, or atrial dilatation, or any feature of atrial remodeling, and are often occurring in patients with practically no background of cardiovascular disease, are not really candidates for any form of thromboprophylaxis. Whereas when the atria become remodeled, even in the absence of other cardiovascular disease, thromboprophylaxis is probably of considerable value. Stroke in association with atrial fibrillation is a major problem. Stroke in itself occurs in some 8 million instances in Europe every year. Some 64 billion euros was spent on stroke in Europe in 2010. It's expected that this figure will double in the next 20 or 30 years. 15 to 20% of all strokes are related to atrial fibrillation. In Europe, we have somewhere between 6 and 12 million Europeans who have atrial fibrillation, and that is set to double by 2050. Atrial fibrillation, as you all know, increases the risk of stroke 5-fold, and importantly, stroke in atrial fibrillation tends to be more fatal and more disabling than other forms of ischemic stroke. So certainly atrial fibrillation plays an important role in stroke, and it's well worth addressing. We have had a whole host of guidelines that relate to this term SPAF, which was really invented by the novel oral anticoagulant companies. They introduced the concept of stroke prevention in atrial fibrillation and called it SPAF. Cardiologists never use this terminology, but it's been thrown at us repeatedly now, and we'll have to get used to using it. We had global guidelines beginning in 2001 with ACC, AHA, and ESC coming together to provide guidelines. These were revised in 2006. The ESC decided to have its own guidelines, for better or worse, in 2010. In 2011, there were updates to the 2006 guidelines, but now attributed to the American College of Cardiology Foundation, the American Heart Association, and HRS. These updates concerned, on the one hand, dabigatran, and on the other hand, dronedarone. The Americans are now completely rewriting their guidelines and will issue new guidelines in about 18 months from now. ACCP have issued new guidelines just 2 months ago, and they have much to say about thromboprophylaxis, and we'll review that in a moment. And the Canadian Cardiovascular Society, having written guidelines in 2010, came up with a complete revision of those guidelines just a few weeks ago. So we have lots of highly current guidelines. The early guidelines were based predominantly on this relationship in terms of the assessment of thromboembolism. This was Brian Gage's so-called CHADS-2 score, simple acronym, very easily remembered. I don't need to go through the details of it with you. I simply want to point out that even at low CHADS-2 scores, for example, a score of 1, there is an annual risk of stroke of around 3%. And if you look at that over a 5 or 10 year perspective, you can see that that's a very significant risk of stroke. And we're talking here about ischemic stroke in atrial fibrillation. So a CHADS-2 score of 1, which previously was thought of as a will we, won't we anticoagulate situation, is no longer thought of like that. First of all, the risk has to be refined. And secondly, because of the relative safety of new oral anticoagulants, the level at which anticoagulant therapy or thromboprophylaxis generally will be undertaken has been reduced from approximately 3 or 4% per annum to nearer between 1 and 2% per annum. So a very much larger population of patients has suddenly become available for consideration for anticoagulation. In the 2001, 2006, and to some extent 2010 revisions of guidelines, this was essentially the resolution that if the CHADS-2 score was 0, a risk of up to 2% per annum, no therapy was advocated, or alternatively aspirin. If it was 1, it was aspirin versus oral anticoagulation, and if it was 2 or more, it was oral anticoagulation. All of these guidelines recognize that there were other risk factors not contained within the CHADS-2 scheme. I'm listing them there, but it'd be better to look at them like this. We had guidelines going back to 1994 from the Atrial Fibrillation investigators, SPAF in 1998, and the first ACCP in 2001. And if you look at the way they risk stratified patients, you can see that they contained factors other than the CHADS-2 factors. So, for example, age over 65 rather than over 75. Female gender was there since 1991. I can't read it. Since 1994, sorry. And you can see other factors, women, thyrotoxicosis, etc., peripheral vascular disease have all been included. So the situation in Europe today is that the CHADSVASC scheme is advocated. You can see it's a more complicated acronym. In addition to CHADS-2, there are 3 other factors: age 65 to 74, female gender, and vascular disease, predominantly peripheral vascular disease, but also coronary disease and aortic plaque. Female gender, I think, is the only controversial element amongst these new risk factors. You can see in the original data set from which CHADSVASC was derived, the odds ratio for female gender was 2.3 or thereabouts, so it was a significant increased risk associated with female gender as it was with vascular disease. You can see the original data set on the left, the 1084 patients from the Euro Heart Survey, and on the right you see Danish figures with 73,000 patients who were not on oral anticoagulants. You can see that the risk increases from less than 1% for a CHADS-VASC score of 0 to 15 or 20% over 10 years. But the one factor that stands out is age, 65 to 74, which is a over 75, which is a very powerful risk factor and clearly much more powerful than these other CHADS-2 factors that score 1. So this is as predictive as a previous stroke. So in CHADSVASC, this gets a score of 2. These are the CHADSVASC scores of 0, the blue line, or 1, the other colored lines, and you can see that immediately the score after 10 years is only 3 or 4% at most. If the CHADS score is 0, if it's 1, most of the factors double or triple that risk, including age, the yellow line of 65 to 74, and the one thing that doesn't meet the criteria that wasn't well validated here is female gender. The effect of moving from CHADS-2 to CHADSVASC is that patients are reclassified in terms of their low, intermediate, or high risk. So with CHADS-2, the gold or yellow bars, you can see most patients are allocated to an intermediate risk value, and therefore under the old terms, we didn't know whether to give them aspirin or a vitamin K antagonist. But under CHADSVASC, you can see that the number of patients assigned a low risk, i.e. 0, an intermediate risk, i.e. 1 or 2, and a high risk is very different to the CHADS-2 profile. Now, the ESC guidelines start out currently saying that antithrombotic therapy to prevent thromboembolism is recommended for all patients with AF, all patients, with AF, except those at low risk, and that's specified as lone risk and less than 65 years of age or with contraindications. And the scheme that is put forward is a flowchart approach where CHADS2 is employed first. If that's 2 or more, clearly the patient needs anticoagulation. On the basis of what I've shown you already this morning, if the age is over 75, oral anticoagulation should be considered. If there are 2 of the other risk factors scoring 1 in CHADSVASC, then oral anticoagulation should be considered. And then 1 other risk factor, oral anticoagulation or aspirin, but the emphasis on oral anticoagulation. If there's no factor, then nothing. Or possibly aspirin, but the emphasis very much on nothing. Of course, we also have bleeding risk, which was introduced into the guidelines. I don't want to say a lot about it because I know it's coming up in another presentation. All I want to point out is that we do have to assess bleeding as well as thromboembolic risk, and particularly in the context of where we might be considering the use of left atrial appendage occlusion, because it's really the combination of high thromboembolic risk and high bleeding risk, which is the predominant indication for devices of this kind. I'll skip saying more about it because it's coming up later. And then I think we have to move to what has happened between 2010 guidelines and current revisions which are taking place. I think that the main thing that's happened is that we've now had reports from 3 non-inferiority trials looking at novel oral anticoagulants versus warfarin, and we see that in all instances intracranial hemorrhage is reduced if the novel oral anticoagulants are used rather than warfarin. Bleeding is reduced generally with the low dose of dabigatran or with the apixaban, and much the same as warfarin with rivaroxaban and dabigatran. And as far as stroke is concerned, you can see that with the higher dose of dabigatran, 150, or with the apixaban, there's a reduction in the risk of stroke. Now, what have guidelines done with these data? Just very briefly, the ESC guidelines only had a footnote about dabigatran because dabigatran was not approved in 2010, but it did say that it was probably a good alternative to adjusted dose warfarin or VKA therapy. Went on to say higher dose should be used when there's a low risk of bleeding, the lower dose should be used when there's a higher risk of bleeding, or if the thromboembolic risk was not high. The European regulators have since added other considerations for a lower dose of this agent. The Americans came out with a very similar recommendation. Dabigatran is useful as an alternative. They don't prefer the novel oral anticoagulant. The Europeans didn't prefer it. They just said it was alternative. They go on to say in whom, essentially all forms of atrial fibrillation, and they should not, with risk, but they should not have prosthetic valves, hemodynamically significant valve disease, severe renal failure. That's pretty specific to dabigatran. And they shouldn't have advanced liver disease. You'll notice it's only level of evidence B because there's only 1 trial, albeit 18,000 patients. Dabigatran will never have a class 1, a level of evidence A recommendation because it's only got a single trial. Now, looking at what the Canadians did a few weeks ago when they published their revised guidelines, they said, take your patients, divide them by, for example, a CHADS2 scheme. If they're CHADS2 or more, oral anticoagulants, CHADS2 of 1, oral anticoagulants, but they reserved aspirin as an alternative for some patients, as indicated by risk-benefit, they put it. They took CHADS2 score of 0 and said, you must risk stratify these patients. If there are no additional risk factors, then no antithrombotic therapy. If the patients are female or they have vascular disease, these are elements of the CHADSVASC score, then they should have aspirin. If they are aged over 65, if they are female and have vascular disease, they should have oral anticoagulants. They went on to say that whenever oral anticoagulants were considered, that dabigatran, rivaroxaban, or apixaban is still pending approval in Canada, should be preferred over warfarin. Preferred. So those were the first guidelines that said that these novel oral anticoagulants are preferred. Then the ACCP guidelines also came out just a month or so ago, and they divided patients again using a CHADS2 system, but they said, for example, CHADS2, and they said in particular, at lower levels of stroke risk, antithrombotic treatment decisions will require more individualized approach, by which they meant using the other risk factors in this category. But if it's CHADS2 equals 0, they said no antithrombotic therapy. So they're more or less clearing out aspirin. They leave aspirin here, but as a patient preference. So it's not a doctor preference. The doctor shouldn't be advising it, but if the patient says, give me something, the only thing you could think of giving them would be aspirin, not an oral anticoagulant. If the CHADS2 score is 1, it's an oral anticoagulant. They do say you can use aspirin and clopidogrel if there is a non-bleeding reason why the patients won't take an oral anticoagulant. Similar advice for CHADS of 2 and above. They also go on to say that dabigatran 150 BID, that particular dose, because that's all that's available in the USA, is preferred to dose-adjusted VKA. They also make a strong statement about a post-ablation situation, for example, or after antiarrhythmic drug therapy, that you should continue to anticoagulate those patients formally. And every piece of advice they give begins with this statement: patients with non-rheumatic AF, including those with paroxysmal AF. This has had to be put in because many patients with paroxysmal AF have been regarded as having relatively low risk of stroke, which isn't true. And these guidelines have made a particular point of making sure that every recommendation begins in that way. Now, we don't know exactly what we will do in Europe in the summer. We have new guidelines coming in Munich, but these are the sorts of considerations. So if atrial fibrillation is diagnosed, first of all, if the patients are less than 65 and have lone AF, including females, of course, then no antithrombotic therapy would be the advice. If they have valvular atrial fibrillation, then currently only VKA therapy can be considered. If they get through the flowchart to this point, the CHADS2-VASC score should be assessed, and it could be divided into a score of 0, 1, or 2. A bleeding risk must also be considered. If the score is 0, it's no antithrombotic therapy, but there is a possibility of antiplatelet therapy if the patient desires. If the score is 1, then the preferred therapy would be a novel oral anticoagulant, and similarly, if the score is 2 or more, less preferred therapy would be dose-adjusted warfarin. And if there is a high bleeding risk and a CHADS score of 2 or more, left atrial appendage occlusion could be considered. Now, that isn't a flowchart from the guidelines, it's just something that I put together just to illustrate thinking about this particular issue. But there will be guidelines about left atrial appendage occlusion in that document, and as many of you will know, there's also a task force set up by ERA to consider in much more detail the precise patient population that could or should benefit from such a device. So I just conclude by saying that everything is changing very quickly as we have novel oral anticoagulants and we have mechanical methods of dealing with thromboprophylaxis. And The big move really is towards ensuring adequate thromboprophylaxis across the board, and that means roughly doubling the number of patients or the proportion of patients with atrial fibrillation that are currently anticoagulated. Thank you very much.
Thank you very much for your presentation. It's not easy to summarize guidelines in a 20-minute talk.